Welcome back, ladies and gentlemen, on our Sunday webinar program. This time we have Dr. Mustafa Arain, a seasoned old friend, trustable teacher. He is associate professor of medicine and director of advanced endoscopy in University of California, San Francisco. We must remember that it is 5 in the morning in San Francisco, and it is very kind of Mustafa for getting up that early and uh, willing to contribute in teaching to the Pakistani community and all the people who are listening to this webinar in the neighboring countries. The topic is very interesting. We all know that Pakistan is suffering from a huge burden of chronic liver disease, and the number of patients who have underwent liver transplantation are sizable, and the number of people who are likely to undergo liver transplantation are again quite a few. And at least 10 to 15% of these people are likely to develop biliary complications in the post-op phase, in its early phase, or maybe in the late phase. I still remember the patients who were coming back from China with tubes coming out of their tummy, and they had to go back to the China to take those tubes out. But as the understanding grew, as the expertise grew, uh, the people stopped going to China for these petty problems. And at the same time, lots of people developed anastomotic strictures, I, Saad Niaz, and so many other people who are in the hepatobiliary endoscopy. We have managed biliary complications following liver transplantation ever since liver transplantation has started in Pakistan. But Mustafa Arain is working in a center which is known for liver transplantation, and they are dealing with biliary complications for a long period of time. He has a very good experience in dealing with these patients. Uh, I um, and before I request Mustafa, Dr. Saad Niaz wants to give a message to all. He wants to say something. So first, Dr. Saad, and then over to Dr. Mustafa Arain. Saad, please.
Okay, thank you very much, Riaz. I just wanted to congratulate you first for having been elected as the president of Pakistan Society of Gastroenterology and all other office bearers from all the chapters. And I hope, and I'm sure everybody else joins me in congratulating you and all those who've been elected. And we pray and wish that we'll be able to in the next 2 years do a lot of good for the community of gastroenterologists and through them to the community at large, and obviously strengthen Pakistan Society of Gastroenterology, which, as far as I'm concerned, is the only society that represents all provinces, all parts of the country, and is the main representative society of those who practice gastroenterology and liver disease in this country. So, congratulations. Um, Over to Mustafa. That's all I wanted to add, Riaz, because I needed everybody,
Thank you, sir. Thank you very
especially
much.
the juniors, to know.
Part of the cabinet, I wish to, along with all of you, with all your support, I wish to bring few major changes in the Pakistan Society of Gastroenterology. Just like you, I wish to that the Pakistan Society of Gastroenterology should be the only society dealing with these things. It's a national society. It's a society with a long history, and I hope and pray that we take the society to its new heights. And obviously, with the support of all the people, we may bring more members from Pakistani community. We may add international chapter. We may add a chapter from the general practitioners, and similarly, the training chapter as well. So we'll discuss it in detail. But right now is Mustafa's time. Mustafa, please.
Thank you, Professor Gas and Professor Sadnaz. Again, congratulations, Professor Gas, on your election. And I'm sure that the society will continue to grow and do well. I think the initiative, just from within this field of pancreatobiliary diseases that you have taken with this weekly webinar is a certainly a positive one, which I feel that not only is the Pakistani community benefiting, but the rest of the world as well. So thank you for the introduction as well. So we'll go over my disclosures. I do consult for a few companies. The indications and anatomic considerations, diagnostic evaluation, what is the role of endoscopic interventions? And I think especially pertinent to Pakistan and Asia, as a whole, the role of endoscopy in living donor liver transplantation, which is primarily how transplants are done, is my understanding back home. So the three main indications are leaks, strictures, and stones. Leaks are quite obvious, usually early on, within days. Strictures can be early. Sometimes they're edema rather than true strictures, but there is a narrowing. And then you can have late strictures that can develop months to years later. And stone formation is usually a combination of strictures, comes in association with strictures or with papillary stenosis of the sphincter vodi. And this can again be a delayed phenomenon. So typically I like to start with this case. And usually when I give this talk to my fellows, I like to ask them what their interpretation of this cholangiogram is. But this was an ERCP that was performed in a liver transplantation patient. And there was a concern for a biliary stricture or elevated LFTs, biliary stricture. But actually, as you can see, if we can look closer on the cholangiogram, there's air in the biliary tree. And even though this may be interpreted as there being a stricture, actually the patient really had a history of a Roux-en-Y hepatocoagulanostomy. So the wrong procedure was performed for this patient with a known liver transplant. And I think this highlights the importance um, of knowing the anatomy before we jump into procedures. It's important for us as providers performing these procedures to know what we're getting ourselves into and what the patients have done. So the ductal anatomy, the type of surgery, and overall having an understanding of the anatomy of the liver is so important for anybody dealing with liver transplantation. Now here in the West, the most common anatomy is still the duct to duct or choledochal anastomosis. These are most commonly performed. They have easy endoscopic access, transpapillary, and there's a wide variety of tools available at our disposal. As opposed to a Roux-en-Y hepatocoagulanostomy, in this anatomy, the issue is that you have to go all the way across the stomach, get to the JJ, and then go up the afferent or the biliary limb to the biliary anastomosis. So now you have to consider doing enteroscopy, and this can require a lot of time, not as many accessories, and therefore the success may be limited with these. Having said that, it can be done. So the other component we all need to be aware of are the types of donors. Excuse me, again, more so here, we can have a deceased donor, donor after cardiac death. There's decreased vascular sort of supply here, so increased risk of biliary complications. And on the living donor side, right versus left lobe, and the consideration here is that the ducts that are being sutured to are smaller ducts, therefore increased risk of complications. Interestingly, less ischemic injury because it's all happening simultaneously. And then you have split livers, which can be deceased donors, but are basically being used as, for two different recipients. And you have variants beyond that as well. In terms of anatomy, I think the basics for anybody doing ERCP, we need to know the segments, we need to know the lobes, we need to know the sectors. So essentially you have three sectors. You have the left lobe, which is segments 2, 3, and 4. And then you have right anterior, which is 5 and 8, and right posterior, which is 6 and 7. This is a diagram I'm sure a lot of people may have come across. If you make a fist with your right hand, then you can try and determine which segments there are. And this is all dependent on the division based on the right, middle, and left hepatic veins. So to the right of the right hepatic vein would be the right posterior, between the right and the middle would be the right anterior, and to the left of the right, of the middle vein is the left um, segment 2, 3, and 4. Moving on to the diagnosis of biliary complications. Usually it's a clinical suspicion. If it's an early complication, patients can be asymptomatic, and just on routine lab testing, one can identify elevations, or on imaging studies that may be done. Occasionally patients will present with pain, fever, jaundice, and pruritus can be a symptom. Now, of course, the primary sort of purpose with all of this evaluation initially is to ensure that there isn't any other cause, but along the way, because imaging is obtained, the rationale is to rule out obs- any reason for biliary obstruction. So how can we do that with imaging studies? Well, we have a lot of studies at our disposal. Ultrasound is good to look for primarily for vascular abnormalities. While we can see some ductal dilation on ultrasound, I think it's more to look at the vasculature. We certainly can look at the ultrasound for intrahepatic dilation or extrahepatic dilation, and that may give us a clue. But the real sort of modality that we rely on non-invasively would be an MRCP. This is a living donor liver transplant MRCP, and you can see that there is a pinch right at the anastomosis. And on the 3D images, as you spin it, you can see that there is an anastomotic stricture. So MRCP is a great tool. It does have its limitations. It can certainly sometimes overestimate or underestimate the presence of a stricture. So it's not a golden rule that if the MRCP is clear, then we're okay. And I feel that that's especially the case when it comes to Roux-en-Y patients. MRCP can be deceptively normal, even when patients have strictures at the Roux-en-Y hepatocogenostomy. ERCP, percutaneous biliary, percutaneous transhepatic cholangiography, should really be considered therapeutic. These procedures, as we know, carry risk, and patients who are immunosuppressed early on in their disease, especially, we have to be careful with being overly aggressive with ERCP or PTC. So moving on to strictures, generally speaking, they're divided into anastomotic and non-anastomotic strictures. Anastomotic are short focal strictures at the site of the biliary duct anastomosis. In deceased donor, they occur in about 5 to 8% of patients, associated with scarring and fibrosis. Non-anastomotic strictures are related to ischemia or other etiologies such as infection, but generally speaking, in one way or another related to ischemia. Increased incidence after after donor after cardiac death. Remember that the biliary biliary vascular supply comes from the hepatic artery, so any issue related to hepatic arteries will oftentimes lead to problems with ischemic strictures. Management-wise, anastomotic strictures tend to respond very well to endoscopic therapy, and endoscopic therapy really, for the most part, as long as we can get there, has become the primary modality to treat these. Non-anastomotic strictures, we're dealing with a different underlying problem. Endoscopic therapy can help. They can be difficult to treat, but really we're waiting on we're guided by how well the vascular supply to the ducts is. These can require much longer duration of therapy, increased morbidity, and decreased graft survival. So starting with strictures, the management is somewhat straightforward. Your principles are sphincterotomy, balloon dilation, stent placement, repeating ERCPs every few months, and this concept of upsizing, putting in as many stents as possible until the stricture is resolved. One can consider fully covered metal stents. They generally seem to be very sort of popular in the West, though one has to kind of realize that A, they are costly, B, in the randomized trials that may show equivalency or even like maybe a fewer procedures, the risk of relapse has been shown to be higher, so that you may get instant gratification, but they may relapse. The principle, however, is that you need to dilate the stricture. So here's an example of a duct-to-duct anastomosis with a stricture and MRCP. The patient undergoes an ERCP. there's balloon dilation performed and subsequently stent placement. It, obviously, the more stents you can put in early on, the better, and then at subsequent procedures, you can do more. In terms of dilation, the general rule is within the first 4 weeks, 4 to 6 weeks, not to dilate if possible because of the risk of causing leakage. But after that, it's safe. Um, there is no like written guideline on how big of a balloon one should use, but intuitively, it makes sense not to go overly aggressive with the balloons, in an effort not to damage the upstream ducts. Here, you could argue that the ducts upstream were both bigger, so the balloon could have been higher. But my sense is that primarily the goal of the balloon is not necessarily to resolve the stricture, but to create space for stents, and it's the stents that really help resolve the stricture. This is another high duct-to-duct anastomosis with the duct-to-duct mismatch. The recipient duct is bigger than the donor duct, pretty high grade stricture. And in this case, you can see initially there's no filling. And one can sort of become disheartened and give up on this. But if you use an occlusion balloon and really pressurize the system, then you can start seeing the filling, fill up the biliary tree. And at that point, in this case, a fully covered metal stent was placed given the high grade nature after balloon dilation and subsequent resolution of the stricture. What if it's early on, the patient's still recovering from their surgery, coagulopathy, concern for sphincterotomy, then we can avoid cutting the patient, just like any other ERCP, where the risk of sphincterotomy related bleeding is high. In this patient, early on, you can still see the staples. PD access was achieved. So when you're not cutting, you're going to put stents in. Theoretically, there is a risk of pancreatitis. I personally have a low threshold for stenting the pancreatic duct because the last thing this patient needs is another complication on top of their massive surgery that they just underwent. So PD stent, get biliary access to the main duct, stricture at the main duct, place two stents side by side. After you, so here I wouldn't necessarily balloon dilate because it's early at the stricture, but I did balloon dilate the orifice to make space for the stents, and then place the stents, two side by side stents. Sometimes the strictures are just too much, too stenotic for us to kind of succeed. And this is actually a slide from my mentor, Dr. Freeman, from when I was a fellow in gastroenterology. And even in that, like this is like what, 10, 12 years ago, we've come a long way with our accessories. They were unable to get across the stricture, and this patient ended up with a percutaneous biliary drain, followed by balloon dilation, subsequent rendezvous with GI, and then resolution of the stricture. Non-anastomotic strictures are more challenging. Here you have these ill-defined sort of almost PSC type irregular ducts with poor filling. And here the challenge becomes that each duct has to be addressed individually. So we're balloon dilating the right posterior, right anterior, and left, and subsequently putting in stents. These procedures tend to be longer and multiple steps, but the principles remain the same. Now, this is a donor after cardiac death, complicated by hepatic artery stenosis. Not much filling. Initially, we were doing the left hepatic duct stenting, and then things just we were getting less every time. Did an Mrcp for follow-up, and this is what you have: central scarring related to ischemia, no specific target for endoscopic therapy. This patient ended up getting percutaneous biliary drains and subsequently underwent a retransplantation because of his severe ischemic strictures and liver failure. So moving on to bile duct leaks. These can occur in up to 25% of patients. The etiology can be an anastomotic site leak, ischemic injury, T-tube insertion, which has really gone out of favor, and surface leaks in living donor or split liver patients. They can be associated with fluid collections and abscesses and generally respond to intensive endoscopic therapy, similar to strictures. I think there has been traditionally a tendency to take patients back early for surgical revision in leaks, but at least here in our institution, there is a tendency to delay if possible and allow endoscopic therapy as the first approach. And if that doesn't work, consider percutaneous or surgical approaches. Generally speaking, the principle should be to try and drain these collections before we go in, um, because the idea is that if you decompress that collection, once you're injecting contrast dye or you're insufflating with air or carbon dioxide, then you don't have a closed system, which is in the interperitoneal space where you're blowing air into it. So getting a drain in first to decompress any biloma collection and then doing the ERCP is generally the preferred approach. Sphincterotomy, again, assuming because this is earlier, they maybe have coagulopathy. As long as it's safe to do an ERC, to do a sphincterotomy, proceed with sphincterotomy. Avoid balloon dilation because leaks are typically associated with strictures as well. And the idea is to avoid balloon dilation because it's early on and you don't want to disrupt the anastomosis more, and then place a stent across the leak. This is not like a post-cholecystectomy leak where you just do a transpapillary sphincterotomy or a transpapillary stent. The idea in anastomotic leaks is actually to get across the leak. Give it some time, give it 4 to 6 weeks, allow the leak to heal up. That's typically when, as the healing occurs, a stricture occurs. So bring them back at a shorter interval early on. And then as they have developed a stricture, typically you can gently balloon dilate and then put in stents. So here's an example of a leak. You can see extravasation of contrast, but eventually getting wires across, putting stents in. I won't belabor this because I'll come to this in the living donor section too. Stones and casts essentially are associated with stasis. There typically it's some degree of stricturing involved as well. There may be other factors such as infectious that we haven't fully understood. Non-anastomotic strictures can lead to recurrent intrahepatic stones and casts. The whole concept of cast syndrome, where you have multiple large stones that conform to the shape of the duct, may be impaired for versus a different etiology. So here's an example of a patient with stones in the bile duct. This is, donor duct, stricture stone, more stones in the distal duct. Pretty standard technique for ERCP, cannulation, sphincterotomy, balloon sweeps, and then balloon dilation of the stricture. Biliary casts can be hard to make out sometimes, and you're like, why isn't this duct filling very well? And then you sort of do your usual thing, and when you do the balloon sweep, you can pull out a whole sort of stone in the form of the shape of a duct, intrahepatic duct. These can be very, very challenging. This is a patient, elderly patient in his 70s, a remote history of liver transplantation, which is a massively dilated bile duct with filling defects consistent with sort of stone casts in the duct. This patient required multiple procedures. We did ERCP standard approach, pediatric scope for cholangioscopy, EHL, um, which gave great visualization but poor sort of access to the stone burden. This is back in the day when we had the cholangioscopy spyglass version 1, which was challenging to work with but broke up the stone. Eventually this happened right around the transition to the SPY 2 2.0, and we got in there, eventually cleaned out all the stone sort of burden. This patient obviously has such a massively dilated duct, not an ideal candidate for surgery because of his age, and does remain at risk for reformation of stones. And this is a phenomenon that can be can happen with transplantation, anybody with any foreign object. So this patient at the time of their surgery had a stent placed. That stent did not have follow-up after the surgery. So presents 5 years later, and it's not initially very obvious, but in retrospect on MRI, you can see this linear filling defect down the middle of the duct, and and subsequently on ERCP, the patient had a stent, stones, and a stricture. So here again, if you have a stricture above which you have stones, uh, primary approach would be to balloon dilate. This is a chronic stricture, so balloon dilate aggressively and see if you can get stones out. If not, cholangioscopy would be a good setting for this patient for stone destruction. if that does not achieve the goal. Here was, aggressive balloon dilation, got the stones out, multiple stents. You can see 310 French stents and 27 French stents. Again, stacking in as many as possible with the idea that that reconforms the anastomosis and the duct. Briefly, endoscopy in altered anatomy, so Roux-en-Y hepaticojejunostomy. Here we have the stomach in place, and so as I said earlier, we have a long way to get to the biliary anastomosis, and typically it's device-assisted single balloon, double balloon enteroscopy. If you have a Roux-en-Y gastric bypass, there you have normal ductal anatomy, but the issue is that you have a bypass stomach. We just have to go the long way and come back. Now, there are techniques to reconnect these two using EUS guidance nowadays with lumen opposing metal stents and then performing standard ERCP. Alternatively, one can consider surgical access, which we have done in the past, though we've moved more towards lumen opposing stents. And then, of course, there is the option of percutaneous access in these patients too. In terms of enteroscopy, anytime we have to use two fluoro shots to get the whole scope in, that it's a long distance to go. But this was a rewarding case, patient with a remote history of a transplant with a Roux-en-Y hepaticojejunostomy, who presented with cholangitis, stabilized with antibiotics. We attempted and were successful in getting there. And fortunately, sort of were able to identify the orifice, cannulating the orifice, and subsequently balloon dilating it. In this case, we did not place stents because a single large balloon dilation, we wanted to see how the patient does, and he did well without any further sort of need for intervention. And the alternative to this, of course, can be that percutaneous access can be achieved. The IR team, our IR colleagues can sort of perform procedures, and then we can sort of collaborate with them and go in through their tracts. This is using a bronchoscope, which is a reprocessable scope. Of course, disposable cholangioscopes can also be used. The company, Boston Scientific, has come out with a short version of the cholangioscope for the benefit of surgeons and interventional radiologists. So I assume that they'll likely try and do more of this on their own as well. So moving on to living donor liver transplantation, this is actually, I think, where the challenges are more, and it's in some ways more rewarding. This is also what is seen more, I believe, in Pakistan and other parts of Asia, so maybe more relevant to our audience in Pakistan. But essentially, these are difficult anastomoses due to the small size of the donor ducts, high incidence of not necessarily ischemic in my experience, but non-ischemic complications. The US data on this, which was the A2ALL study, reported a recipient leak rate of 32%, stricture rate of 17%. The donor leak rate was 9.2%. Now, this is going back several years, and at that time, and once living donor transplantation took off, it took off significantly in Asia, and the volumes are much higher there. What's interesting to me is that the data that comes out of Asia generally speaks of relatively much lower incidence of biliary strictures and also lower success rate of endoscopic therapy of strictures compared to what we see in the US. We seem to have a higher stricture rate, but seem to have a higher reported success rate when it comes to endoscopic therapy. And I feel that perhaps it may be practice differences, at least in the reported literature, of how these strictures are addressed or these complications are addressed. So here again, the reported rates are 60 to 80% response to endoscopic therapy, need for surgery in 50 to 60%, high rates for PTC surgery. And I always question, is that really necessary? Because I think as the tools and our techniques have improved, our success rate has improved. Here, the principle is that the anatomical considerations and knowledge are important. The surgical considerations are also important for the endoscopist to know. But the idea is sort of there may be more than one approach, but I can only speak for our center's approach, where I've practiced, where we would typically aim to obtain access to both the right anterior and right posterior ducts, individually balloon dilate them, and place stents. Typically start with a 7 or a 10, whatever we can get in, and then eventually we can put in more than one if there is space, with subsequent, the whole concept of upsizing and following up, and eventually when it looks like the strictures have resolved, then removing the stents. The other concept, I think, for biliary endoscopists, especially dealing with these anastomatics or transplant strictures, is not to be hesitant to get cholangiograms. I think there is a tendency by some people to limit contrast or limit fluoroscopy. You are doing a fluoroscopy-based procedure, which has implications for the patient's, several hundred thousand sort of dollar or, rupees sort of procedure. So it's important to get meaningful information. So I actually like to do balloon occlusion cholangiograms to evaluate the intrahepatics carefully, as well as the anastomoses, to see what's going on, and also to document that the stricture looks okay at the end of before we remove our stents. This was a living donor liver transplant, and it highlights some of the, left living donor liver transplant, highlights some of the issues that we can run into with left or right sided strictures or transplants, that oftentimes the scope isn't perfectly in a reduced position like we're used to with non-transplant anatomy. And then on top, you have these sharply angulated ducts, whereby pushing devices through can be very challenging. On top, this patient had a very high grade stricture, where the only thing we were able to get across was a 018 wire. Not even a tapered three to five French cannula could be used to get across the stricture. So in this one, we actually ended up using a Sohindra stent retriever, because we knew from the Mrcp that the upstream duct was dilated. Had it been small, I would maybe have been hesitant to use this, but we essentially used the Sohindra screw stent retriever. You can see the torquing that's happening, but as we keep advancing it, it eventually pops through the stricture, making the opening accessible for further. There you go. Now it's gone through. Now it makes it easier for us to subsequently balloon dilate. You can see the waist on the balloon, but you can also see the dilated upstream duct. Balloon dilate this aggressively because this was, over a year out. In this one, because of the high grade stricture, I placed a fully covered metal stent intraductally and did place a long 10 French stent with multiple side holes out into I believe this is the segment 2 or 3 duct. I can't tell exactly, but it looks like 3 maybe. But regardless, put in a stent and then gave the patient 2 months, brought the patient back, removed the stents. The way to remove these intraductal metal stents would be to put in a rat tooth forceps and grab the stent. And generally, if you don't delay this too long, it's relatively easy to remove these stents that way. And on occlusion, this is completely resolved. And 3 years follow-up, LFTs are normal, imaging is normal, and the patient has not had another intervention. Anastomatic leaks, these can be pretty problematic because now you're dealing with potentially more than one area of leakage. And the goal here is to get the access, again, above the leak into both, this is a right-sided living donor liver transplant, into both the right anterior and right posterior. And so this may require some time and effort, but I think the key is not to it's a balancing act, not to be overly aggressive where you damage the anastomosis more, and not to be under aggressive where you're not doing a good job of trying to get across. And one may have to use different wires, different catheters, angled wires, straight wires. The key is having those tools at your disposal. Again, when the effort's gone into building a program and using, putting a patient through this high cost procedure, which is a life-threatening, life-saving surgery, then as endoscopists, we have to do our part to make sure that we do whatever we can for the patient's sake. So these procedures can be long, but it's worth the effort. So right anterior access, right posterior access, very decompressed ducts. In this setting, it may not be feasible to put 7 French stents in. So we just started with 5 French stents and actually gave the patient just a couple of weeks, allow the leak to settle down some, and then bring the patient back. Now the ducts have dilated up a bit more, get access again, and now we can upsize them, in this case to a 7 French and an 8.5 French stent. And at subsequent sort of follow-up resolution of leak, but you can continue because they're almost certainly likely to get a stricture here. You can actually go 10 and 10, or 8.5, 8.5, and then eventually remove the stents as needed. This was a patient from about 10 years ago. We saw that there was a leak, but it looked like there was filling of the stomach gastric lumen. We pulled back our scope and we could see that there was a fistula to the stomach. So this now becomes like a cyst gastrostomy of sorts. We got into through the fistula tract, lavaged the tract, placed balloon dilated it, because you're trying to decompress this bile leak essentially now through a transgastric approach. Balloon dilated it, placed a stent across it, and placed a transpapillary stent into it, and then a stent across into the anastomosis. Here we only got into a single branch. On follow-up, we brought the patient back. This is after multiple procedures, but eventually resolution of the stricture. Again, perhaps this patient might have been taken for surgery in other centers, but with the backing of our surgical colleagues, we were able to manage this endoscopically. So the other component of this is, again, an importance of knowing the anatomy. So in this patient, the patient's right posterior had been sutured to the cystic duct and the right anterior to the main duct. And had we not known, we could have just been sort of filling part of it and not understanding why we're not getting the other one, or why we keep pushing our wire up and we can only get into a single side, because the takeoff of the cystic is much lower. So the access to the right posterior was going to be much lower. This highlights again the importance of knowing the operative anatomy, and the instruction to my fellows is that do not start the case before telling me what the surgical anatomy is, when the surgery was done, what are the ductal sort of anastomoses. And then once we have that, this patient had a leak not from the right anterior, but from the right posterior cystic anastomosis. Placed stent. Again, even though the right entry is okay, you could have argued leave it. Generally speaking, partly for transpapillary drainage, both sides were stented, and eventual resolution of the leak and stricture. Now, this is probably the toughest and the most sort of challenging cases when they're on the schedule, but a living donor with a Roux Y hepatico J, because the goal is to get there, and when you get there, working with very limited resources because of the accessories available, and seeing if you can accomplish much. So this patient did have, by sort of both right anterior and right posterior duct strictures. You can't have multiple wires. You have to do one wire at a time. Getting a wire into the right posterior because it's more angulated, getting a stent in there, and then putting a wire up in the right anterior, and then putting a stent in there with eventual resolution of the stricture. Then you have to go back and pull the stents out one at a time as well. And of course, donors can get leaks too. So in this patient with a donor leak, this is at the cut surface where the right hepatic duct takeoff was, identifying the leak, getting a wire across into the left system, placing a 10 French stent out into the left system, a second shorter stent transpapillary for decompression. One could argue this is overkill, but in the scheme of things in the US, the cost of a single plastic stent isn't very high. So the more decompression, the better is the hypothesis. And so I placed 2 stents with eventual resolution of the leak, as shown here. So we looked at our experience at my previous institution at University of Minnesota for living transplantation uh, complications. And what we found was that we had 40 patients out of 46 out of 100. So again, a high complication rate with all sorts of different anastomotic variants and underlying liver disease etiologies. And out of the 46, 43 patients had ERCP as their initial intervention. Three went with three went to surgery directly. Of the 43, 40 were managed with ERCP alone. So 93% of patients basically off the bat were treated with endoscopic therapy alone. Two went to percutaneous access, of whom one required ERCP um, after the percutaneous procedure, and one was a PTC after failed ERCP. And one out of the ERCP group went to surgery. Again, the leak rate here was 6 patients had a leak. So 5 of these were duct to duct, 1 Roux-en-Y leak. Of these, 3 are the ones who went for surgery. Sorry, 2 who went for surgery. The key point here would be that initially the stricture group, whether it's leak and stricture or stricture alone, generally speaking, did end up with endoscopic therapy. The median sort of number of procedures was overall for all comers was 3, but ranged from sort of 2 to 13. And overall success rate with endoscopic therapy for all comers in whom it was attempted was 93%. For strictures, 95%. Um, Recurrence of strictures did occur in 13 patients. 12 out of the 13 were treated with endoscopic therapy with additional need for stenting. And those patients, at last follow-up were doing well. Duration can be long. Typically in living donor liver transplantation patients, I'll be interested to know how our colleagues in Pakistan sort of approach this, but I typically tell them it'll be at least a year, sometimes less, sometimes more, and that way you just set expectations with intervals of 2 to 3 months for repeated ERCPs. Subsequently, we've also looked at our much larger series at UCSF. This has been presented in the form of an abstract and will be published soon, but essentially similar results, about 40% complication rate, but key point being that good response to endoscopic therapy. The time of stent place, duration for which stents are needed seems to be going down as our experience overall with this disease is, or this complication is improving. And the response to endoscopic therapy, there is a overall better sort of response as our experience has increased. So how have we sort of gotten there? I think part of it's the learning curve that we've overcome with time. The other component to this is how willing and aggressive is one to spend the time and try and address these problems. My personal favorites, I would say, is this swing tip cannula, which can be bowed in 2 different directions. This is from Olympus Endoscopy, using this with a wide variety of wires, typically starting with a straight VisiGlide, moving to an angled VisiGlide, and then turning to a glide if necessary for the complicated sort of angulated ducts that the Visi isn't cutting it, and sometimes downsizing to an 018 wire. These 10 French multi-fenestrated large side hole sort of stents up to 22 centimeters long, the Jolien stent. This is from Cook Endoscopy. These we've had a lot of good luck with. Covered metal stents, again, I think not necessarily for living donors, but in deceased donors, they have a role. Though I'm actually sort of, I've gone full circle. I started plastic, started going to metal, and now I've gone back to plastic. I think plastics tend to have better outcomes than metal stents. And then cholangioscopy can be used, it certainly can be used for duct access, but also, of course, for stone removal and destruction. So I think the technology improved, our techniques have improved, and as a result, we are getting better in terms of dealing with it endoscopically. I will say that it should not be perceived that GI or endoscopists are the only way to deal with these strictures. This has to be a multidisciplinary management, close communication with the transplant surgeons. All our transplant surgeons and I sort of talk directly about these patients. We have coordinators, we have nurses, but I like to have a surgeon to physician communication about these patients. Um, so in summary, these are complications are common. The non-invasive imaging studies like MRCP are helpful, and ideally should be done before endoscopic procedures. Uh, Endoscopists dealing with transplantation complications need to be aware of the anatomy and the type of surgery that the patients had. And I think in today's day and age, I would say that over 90% of patients, including living donor transplants, are responsive to endoscopic therapy. And hopefully we can reduce the number of patients who need reintervention with surgery as our experiences continue to grow. And with that, I'll end. Thank you.
Thank you, Mustafa, for an excellent talk. That was a brilliant presentation of a very complex topic. There are lots of questions. Professor Anwar Khan is here. There are so many other people who are very well versed in the post liver transplant patients. Is
Mhm.
the living related uh, liver, uh, liver donation and deceased donor liver donation, the strictures, are they the same kind, or you think that these two different type altogether?
I think um, the biggest difference obviously is the amount of space we have. For a duct to duct, there's so much more space. It gives us the ability to do more. Sometimes, though, I will say that there just seems to be this shelf of scar tissue with both, whether it's living or deceased donor, which can be very challenging. Generally speaking, the deceased donors are easier to address than the living donor strictures.
Hmm. Now, why do the people get more choleostresses and stone formation in the post liver transplant patient? Do you have any explanation to that?
I think my apart from the fact that they have strictures, or they may have a mechanical disruption of flow at the level of the anastomosis. I haven't really looked at this, and I'm always trying to figure out how best to look at it. But the phenomenon of papillary stenosis seems to be there too. I think there is a stasis component or decreased flow at the level of the papilla, which may be contributing. And then there may be intrahepatic processes at the cellular level that are not necessarily related to the anastomosis, but the fact that the patient is, some sort of an immunologic issue that may be beyond a flow issue that may be contributing, is my sense.
There's another question. Is there any way to assess whether the stricture is more because of the rejection or because of the ischemia? Is there any good way of judging between the ischemia and inflammation arising out of the rejection?
Um, so ischemia, it depends if it's an arterial or venous phenomenon of a big vessel, then that's where the imaging studies like ultrasound, CT, MR, venography, arterography, etc., can help with figuring out whether or not it's a vascular phenomenon that's contributing to it. Um, Oftentimes it boils down to getting liver biopsies and trying to determine it based on the liver biopsy results what the underlying etiology might be. So I guess that's my take. I will say that here in the U.S., the the hepatology side of it is not managed by us. That is the transplant hepatologists. So they may have other sort of thoughts, and you may have thoughts in additions, or Dr. Saad and Dr. Anwar may, um, beyond sort of my knowledge on the specifics of these topics.
I think it's a very interesting subject. Professor Anwar Saab is the most seasoned out of all of us. He has dealt with more liver transplant patients as compared to us. After talking to Subhash Gupta from India, For the past many years, I'm giving at least 3 days shorts of corticosteroid before touching a patient with post-liver transplant stricture. But let's hear from Anwar Saab and Saad Saab as well, and then anybody else who wants to give comment. Anwar Saab, please.
Thank you. Like always, uh, Mustafa, this was a great talk and your extensive experience in dilation of the difficult strictures. Uh, I think, there is definitely, we are dealing more with the liver transplant from the live related donors, seeing very tight stricture at the anastomotic sites, anterior posterior ductal strictures, and also seen a lot of these patients with the proximal stones, which are difficult to extract. So these are some of the things which are hard to really see why they're happening in the post-transplant patients. I don't think there's a really good research on this, or the analysis of the bile, which is maybe different.
Mhm.
And again, talking to the Indian colleagues like Subhash, they tend to put smaller caliber stents rather than 10 French stents in these strictures, because they think that the 10 French can get impacted and prevent drainage, like, and the side holes are too tightly in the duct, prevent drainage. So their tendency is to put 7 French stents, two at least in both ducts, and just extract the stones as you go in. And these are usually what we see as black stones. Probably more of one would see with the PVC type of stones. With our limited experience, I'm not really for the workup of the biliary contents to see why these stones are forming. I really have no answer to that. But with our experience of dilating these strictures uh, to the maximum size, and then putting smaller caliber stents, plastic stents. I have no experience of putting metallic stents, because uh, in the live uh, donor transplants, because they're usually small caliber ducts, and leaving a metallic stent distally may not be accessible to us. So therefore, I didn't take a chance of putting intraductal stents, metallic stents. So I think this is what I can really say about these strictures. Uh, I have a patient who is not a post-transplant, but a post-cholecystectomy strictures, and we keep bringing her back for last several years. Leaving a stent in gives her extreme pain, which I don't understand, but every time we put stents in, she comes back with extreme pain, and we have to take the stents out. We every time we dilate to 6 French or 8 French, and then she does well for 6 months, and leaving a stent in with a lot of pain. I don't know, in your experience, why should she get so much pain, and we have to remove it each time. Thank you.
No, those are excellent comments. I think uh, first, to answer the issue about this one patient, bile leaks in women, especially I feel young women, they can really ruin their lives. I think they're left with a hypersensitized state, and that becomes a problem, that the stricture may be gone and the leak may be gone, and they have problems. In her, of course, the stricture is recurring. One consideration might be to do a cholangioscopy to see there isn't an issue that may be leading to stricture formation, like suture material or some sort of a clip device. Just, those things have been associated with recurrence or persistence of strictures. So cholangioscopy to assess the intrahepatic anastomosis or intraductal anastomosis intraductally might be one sort of option. With respect to your comments on the intrahepatic stones, it may be possible that we're also dealing with different diseases. I don't know if it's more Hep B versus Hep C over there, but here it's been alcohol and Hep C. I don't know if that has something to do with it. I think there are components of it on the in the intrahepatic aspect, again, immunologic, that we may not fully understand. We tend to get in relatively early and be aggressive, I think, at least based on the literature compared to what I see coming from our colleagues in India. And so I don't know, pigmented stones, we get them sometimes, but not very often. Primarily, we're dealing with strictures, but we have a low threshold for going in and then putting in stents. 2 7s versus 10s makes perfect sense. The 10s that we've typically used, or 10 and a 7, are the ones with multiple side holes. A standard cotton Lyon 10 only has one hole, and I agree that there is a risk of it becoming occluded. And that's why we prefer not to use those. Some places clearly do, or use 10 French pigtail stents. I don't like to use those because they get kinked. Um, but the ones with the multiple side holes seem to have good flow through them.
Masud, do you have any experience with Swandra's strength retriever in managing the strictures in post-liver transplant patient?
I just showed the one case where I did that for getting access, but I don't typically use it just because of it potentially, causing damage if it's a small duct upstream.
Mhm. And when exactly do you say that the stricture has been managed well? When is the time that you feel satisfied that the stricture has been
Mm,
taken care of? It's time to
yeah.
say, okay, now you can go home. Don't come back for a repeat TICP.
Yeah, I think that's a tricky one always, but when I do this power cholangiogram, and not just the cholangiogram, but also when you're doing the balloon sweeps, you don't feel that give, and the balloon tends to come through easily. And then on the cholangiogram, things are looking good. That would be when I call it. I usually err on the side of doing it for at least 6 months, 6 to 8 months before pulling out. And I think living donors, if we're a bit too confident early on, we can be back in there within a short period of time. And then our transplant sort of coordinators are monitoring the numbers. Even if the alk phos goes up a tiny bit, they'll be like, should we get another ERCP? And I'll usually try and hold off and give it time.
Is there any difference between early and late strictures in post-liver transplant patients, especially the living related? And I shall request Saad as well as Mrcp to respond to that. Khalid is also there, Nadeem is also there. Early and late strictures, say people presenting with biliary strictures early on after living related liver transplantation within the first year, and then presenting late in their course um, in
You,
the second or third year.
Mustafa, are you responding to
And
that question?
I think you are responding. I have an opinion,
Okay,
but we'll wait for your response.
okay. I think it's very similar to what I've seen and my own experience. I feel the longer there is a delay in dealing with the stricture, the more difficult it becomes, and the longer you need to keep it dilated.
Yeah,
That's what our experience has been.
extensions are required.
The I think that applies to most strictures when you look at their management. And so I think it's a general principle. But one of the things that our practice has been, like Varsab said, we always go in with a 7 French stent. My aim is to get in 2 7 French stents in the anterior and posterior system. And if I've got them in the first go, I'm pretty happy. When I bring the patient back, depending on where they're coming from, obviously a lot of these patients come um, from different places and cities. So when they come back next time, we then actually go in and to try and put a 10 French stent in both the systems. I just put straight CL stents, and so far in the last, been doing it now for a very long time. We've not really had any significant problem with either stent impaction, stent issues related to using single straight stents. Cheap, they're simple, they're available. So that's the take on the size of stent. Occasionally, obviously, in some patients where, like Mustafa said, we just pull the balloon through, and I think that's the biggest confidence giver. When you can easily pull the balloon through the stricture, it says, okay, fine, we are good. However, I always tell the patient we don't have the systems like the West, so I always tell the patient that if you have any issues, i.e., fever or other issues, then you should straight away come back. A lot of them don't come back for follow-up. One of the major issues that we have is patients get the stent, they get better, and they don't want to come back at the time you want them to come back. And that is one of the problems I've had with stenting in the biliary system or even in the pancreatic system for that matter. Even transplant patients, sometimes they just disappear because they're well and they don't see why they should come. And obviously cost must be a factor as well. So that the other thing that I just wanted to share is about intubation or passing into the pylorus. Sometimes it's difficult in the standard position of ERCP that we do. So quite often I have my patients the left lateral to start with, get into the duodenum, and then put them back onto the prone position, which is what I generally use for my ERCPs. One of the things that I always suggest is that I with Anwar up there and all the other colleagues, I feel that this is the most difficult ERCP that I do.
Intubation
And sure,
is also tricky.
see, so the whole procedure, in my opinion, getting into both the systems, getting the wires through, we have limitations when it comes to accessory. We don't have the I don't have the luxury of having all those cannulas that were shown. Sometime not even the wires, although the glide wires are amazing if you have them. But balloon, and you can use the sphincterotome to play snooker or carom. That's how you get into the system that you want to. So you hit the other wall and take the wire to the side, and that's what we use for flipping. Unlike the flipping cannulotome or cannula that was shown by Mustafa. The other point I think is very important where you can shed some light. And I don't use steroids at all. And I think the success that we have seen is really very close to what I have heard from others. So it's not really any different. But one of the issues that I have seen is the infection, cholangitis. So I learned it from my Indian colleagues, and all our patients now are on IV antibiotics for at least 72 hours. That's what I've seen that's what I've seen them do there. And so hence we are doing it. This is anecdotal. This is not based on any evidence, and I don't know how one is going to get one. But I wanted to have your views on that. So this is what I would suggest. Thank you very much, Mustafa. It was an excellent talk.
Thank you. I mean, excellent comments. I agree. I think the positioning thing is important, starting sometimes left and then putting them prone. In terms of the steroids, I personally have not used them. I'd be interested in Professor Yas's comments on that. I will say that generally steroids have been recommended for other strictures, and I'm not so confident they do too much of a job, but we try them, and if they work, great. But I'd be interested in Professor Yas's comments on that. When it comes to antibiotics, a couple of years ago, there was a request that we don't give these patients antibiotics at all. And I was very, very disturbed by that, because I have had patients who, despite antibiotics, come back with cholangitis. So I wouldn't say our institutional protocol, but again, my sort of non-scientific / sort of biased approach is 1 dose of IV antibiotics peri-procedurally, and then 5 days of oral antibiotics. And I think 72 IV I assume these patients are then staying for 3 days. That would be very hard to justify in our healthcare system. Our patients
they don't stay in, so they go home and they get the IV antibiotics there. But having said that, I agree with you.
Yeah. So I think it'd just be logistically, it'd be a nightmare to arrange home IV antibiotics here with our healthcare system. But so I do give oral antibiotics, and I have no sort of problem justifying it. But at the same time, can I say I have hard data to back it up? Not really. But that's my approach.
Can I just ask one question? Mustafa, you were very brave in doing a cholangiogram with the obstruction balloon with a very tight stricture where the contrast did go proximally. And my fear in such kind of stricture is that if I cannot pass my guide wire through the stricture, which sometimes does happen, then none of my radiological colleagues are going to attempt to get into a very small ductal system, and the surgeons, there's no backup. So I think, what do you do with those situations when you have a contrast gone proximally and patient has a raging cholangitis and
Right.
you cannot get through?
Yeah, that's an excellent point. I think the two components. One is, again, we have a lot of tools at our disposal, so it gives us the confidence to be aggressive and see if we can, switching to a fourth wire is not a problem. It's a matter of what do you have that you could try different that may work. So we have all those devices available to us, which makes our life a bit easier. And I think our system here is set up such where we do have that backup. To my recollection, there was one patient just in the last actually year that I can recall in the last 5 years where this situation occurred. It was a sharp angulated duct, but it wasn't in a duct it wasn't a normal anatomy. It was a roux patient. So I just didn't have the tools. I was restricted, with one cannula, one type of wire, where I was filling and I couldn't get through. And it kept happening. And at one point I said, okay, we're done here. It's a one-way valve right now. I'm putting contrast and this patient's going to get cholangitis if I keep at it. So we had already given him antibiotics, got him admitted to our transplant team, and the next day IR put a percutaneous drain in. I think the perhaps setting that expectation with the patient that we don't know how tight things will be, and it's possible that you may need to be admitted. Um, Generally speaking, I don't know how, even with the living donors, because they tend to be in better health in the US than maybe back home. Um, that setting expectations that when you have this living donor, it's not going to be smooth sailing afterwards. There could be complications, including biliary complications. So I think setting that expectation with the patient up front that, you may need more interventions and you may need to be admitted afterwards would be the way I would say one could approach it. But, it's hard for me to give you advice, Professor Noir. I can only speak with my experience. That's all.
Well,
Okay,
can I
one
ask
last question. Maybe
Mm.
I did a lot of, I'm sure, uh, burning questions, but I had experience in the US here with a patient who had a gastric bypass and put an axial stent to access the ampulla. Uh, do you access it like Todd Barron does in the same sitting, or you have them come back after a week or 10 days after the axis is firmed up and you don't dislodge it? What is your approach?
Yes, my personal approach is if it's an emergent situation, then I wouldn't necessarily do it. And I would maybe do lap access if I really need to get to it. I don't feel comfortable doing it in the same session. So if it's like papillary stenosis, pain, etc., that the patient can wait a few weeks, I've actually waited 3 to 4 weeks before I go in. I have a patient with PSC who basically had the situation, and she had elevated LFTs, but she wasn't cholangitic. So we put the Axios in and then brought her back. And now we're using that routinely for her ERCPs because she's probably headed down this pathway of transplantation. But the initial, I always try and wait 3 to 4 weeks.
Can I can I comment on that? So this edge procedure, when you put a stent in there, and if you do in the same session, there is a high risk of dislodgement of the stent. So the same session usually you have to do in cases of cholangitis. The other cases you can get away, really put that in, wait for 10 days, 2 weeks. But there are going to be situations when you have to do during the same session. So in those cases, options are you stitch the stent, the proximal end, you stitch that to the wall, gastric wall, so stabilize it. And when you have to do that, if I have to do that, I have a smaller 140 scope, the old ERCP scope. It's not available commercially, but we have one, and we use it when needed. And in those cases, cholangitis cases, I'll just put a stent. Don't do sphincterotomy. Just get in there, cannulate, put a stent in, and get out.
Khalid bhai, I know this is going to sort of distract us from the topic, but one of the other options we have is the over-the-scope stent fix, OTSC stent fix, which can also be utilized because we don't have access to endoscopic suturing here. So that is another option. But I think I agree, and obviously the one I've only done with your and Mustafa's distant supervision, or the one as you've suggested, by leaving the stent in and coming back in about 2 weeks' time. And can I just very quickly comment on the topic of recurrence of cast formation in patient post-transplant? I think there are a number of theories around. I think one of them is loss of this bicarbonate umbrella, which is lost, especially as the patients are given multiple antibiotics and they're on immunosuppressants. And that tends to happen in those patients, again, who've had any post-transplant complication early on within first week post-transplantation. There's in terms of, I think somebody had already asked this question, Mustafa bhai, if that is with regards to the optical diagnosis to determine what sort of stricture you're dealing with. And I think you've already alluded to, and you've probably answered the question. I'm sorry if I'm going to again distract you from the topic, but in terms of using the cholangioscopy in this case, does that help at all? One. And number two, I know again, maybe a bit far-fetched theory, especially in cases of deceased donor transplantation. What about using EUS access and rendezvous position when you are unable to access? I know that doesn't happen in your practice, but just as a question.
So, you know, my personal bias with cholangioscopy is that it's great for therapeutics. It's not so great for diagnostics. I think we can go up there and look. And I did that on a transplant the other day because we could squeeze in 5-10 French stents, but there still was a shelf. And we proved by looking that there was a shelf, but also that you can get across. You know, beyond that, it doesn't, in my personal opinion, and others may differ from me, that I think it doesn't add too much value. You know, so I think, yes, you can look, but it's really the proof is in the pudding. If the patient does well and your bile's flowing, you know, it doesn't matter what the cholangioscopy shows. It's really how the drainage of the bile is that's going to determine how they do. So I'm not quite sold on the role of proving with cholangioscopy that it's resolved. I think cholangiography, balloon sweeps tend to probably give just as good a result. Now, time may tell differently once we get more experience with this. With respect to EUS access, that's always an option in a situation where you can get to the upstream duct via EUS. It's tricky because here you will have to come from, because it's a duct to duct, you'll have to come from above the anastomosis, which will be very proximal, so it won't be easy to come from the bulb. So you may be looking at a transgastric, transhepatic access. And sure, you could do it. You know, I haven't had to sort of fortunately do it. But at the same time, it's a feasible option if necessary. But, you know, you're also dealing with immunosuppressed patients, and sometimes it's okay to let go and say, you know, we couldn't get this one. Let's have our IR colleagues deal with this, and we can always internalize them afterwards. So just because we can doesn't mean we should, I guess would be my point. So,
One last question.
mm-hmm.
When you say that a stricture is resistant and it's good time to give it to the surgeon?
That's excellent. I think partly determined. So the challenge there is for these living donors, you trade one problem for another, because if it's just recalcitrant to the point that you cannot do much more, and they're getting multiple procedures, and we're just like in a fixed state, we're just doing maintenance here, and it's not going away. They can operate. The challenge is that then they can get an anastomotic stricture at the hepatico J with a small duct, and now you're going to have to then put in PERC drains. And we've had some of those patients where we went from that to PERC, and then they're calling you to do an enteroscopy RCP. But I think the answer to that is when the patient's tired of it, and also when it's been roughly over a year. I would say when it's been like over 12 to 18 months, and the patient's fatigued and tired of it, and the surgeons have said, if the endoscopist says there's nothing more, then typically it's a back and forth with the surgeons and the patient whenever they're ready.
And Mrcp, will you like
And
to add anything to this?
Yeah, I think the surgeons are also not very keen to jump in these cases because, obviously the surgical, post-op care and all that in immunosuppressed patients can be fraught with problems. Our IR colleagues, like, uh, you know, they are sometimes very aggressive in approaching these strictures transhepatically and leave the stents in, like internal external stents in for a long period of time, like 5 to 6 weeks, and then keep coming back and redilating and ultimately leaving it to a point where the stricture is resolved. This was also the approach, one of our colleagues at Harvard, he works with us in Doctors Hospital. So I think it depends really what you have in your institute and what is available and how confident they are. And that is the final approach, I think, as we
So
do.
the question was pertaining to a structure which has been managed well with the endoscopy. Stents have been placed and we are replacing the stents continuously. But every time we think that the structure has been taken care, but then the structure comes back and we again have to go in, repeat the ERCP, put in few more stents and few more sessions. So when should we call it a day that, okay, we have had enough sessions of ERCP, we have put in, every time we have put in 2, 3 stents, and we have done adequate dilatation, we have left the stents for a good period of time. But now they, once we take out the stents thinking that the structure has been taken care of, uh, 2 weeks or 3 weeks down the road, patient comes back again with the obstruction.
Yeah, yes, I think, we all have this, observed this, that the stricture is always going to be there. It's not going to completely go away. It's not going to look like a distal and the proximal ductal size, and the alpha is going to stay up. Gamma GT is going to stay up. Depends how these patients are doing clinically. If they're getting cholangitic, if they are getting, stricture becomes as tight as it was to begin with, which can lead to, failed level transplant, organ failure. If that is not the issue, we can just live with it and have the patient get assessed by Mrcp. If they're not symptomatic, I just leave them alone. Sometimes, chasing the stricture size and chasing the radiological pictures is probably not conducive for a patient's outcome. I've had a couple of patients post-liver transplant from China, and we aggressively treated the strictures, and ultimately, the strictures got partially resolved, but the patient is doing very well. I mean, you know, so I don't know. I mean, Saad may have a different idea, and Khalid may comment on this. But this is what I think, that we should not really aggressively treat the radiological pictures rather than observe the clinical outcomes too. Thank you.
So well, my rule is after like 3 RCPs, if the stricture is still there, the way I sometimes, I think this is a very valid point. Is it this, are we looking at just really a radiological study to comment that the stricture is, or it is really clinically significant strictures? And many times it may not be a clinically significant stricture, and we are just treating the radiology there. And I also, for us, it's mostly liver, not really a live donor. It's a diseased, those transplants and those anastomotic stricture. One thing is I assess with the 8.5 millimeter inflated balloon, if it can go up and down, both inflated, for me, that's a good indication that it is good enough for dilation. That's one thing. Second is, if I have to do 3 ERCPs, that's the point where I personally consider a spyglass, because I have seen clip there, I have seen a suture there, and in those cases, I will remove that and then really start over from there.
Mhm.
Good. Dr. Asabek from Gambit had put up this question. I'm sure that he must have got the answer from that. It's already 7:20. It's very early, I know, in the United States. I'm really thankful to Mustafa. I'm really thankful to all my um, uh, American colleagues, similarly from UK and from rest of the world for sparing the time. Thank you all colleagues for joining in the webinar. Um, have a very good Sunday evening and wish you a safe safety from COVID. See you next Sunday. Take care. Assalamu alaikum. Bye bye.